We'll actually be able to hone in on some of the cases that we just went through additional cases. So I'm hoping that this will be a practical lecture. It's certainly not comprehensive around each complication, but I think from our perspective, we need to make sure we understand which patients need preventive therapy and which patients really need to be seen quickly to address complications. Okay. I need to click. Great. All right. So here are our cases, sort of covering the bases. So retinopathy, diabetic kidney disease, neuropathy, and of course, cardiovascular disease. Okay. We're going to start by just quickly reminding you about the glucose hypothesis. I like to use words like glucose is a toxin over many, many years. When it's high in your blood, your body knows how to use glucose, but when it's too much, parts of your body are not designed to handle it. I use those words with my patients because I think it describes the problem well. High glucose does not hurt the body acutely unless it's, very, very high. It's really it's a marathon, not a sprint, as they say. So what we know is that glucose over time, hyperglycemia can lead to diabetic retinopathy. So the retina is very sensitive. The renal glomeruli are very sensitive. Larger and smaller nerves are very sensitive, but to point out that smaller nerves like autonomic nerves and very small peripheral nerves, they are more sensitive to maybe acute perturbations in glucose. But for the most part, we're talking about a long-term exposure problem. So the mechanisms, we won't go through what you've learned in medical school because I need you to stay awake. But the big picture is that this has not changed. Our knowledge really hasn't advanced beyond this old slide, where glucose, when it's excessive, leads to oxidative stress. And this is basically cells not knowing how to deal with overnutrition. And there are some pathways that help put the trash out, where this extra glucose is sort of eliminated, but that leads to some production of secondary proteins and negative proteins that can have a negative impact on normal cellular processes. The tissues that don't have insulin blocking the door are the ones that are most sensitive. So those are the ones I just described to you. One quick sort of identification for you is the advanced glycation end product. These are products that are soluble, they're in the bloodstream, but they can also attach onto tissues. And I think that probably the best example of that are the soft tissue complications we see, including Dupuytren's contracture, where patients can actually see for themselves the impact of glycosylated tissues. They become abnormal. Now, the big question is, at what point is high blood sugar? Because if our bodies are used to managing and metabolizing glucose, how do we know what's too high? And the only way that we've really explored this carefully is through retinal disease. The retina is extremely sensitive to hyperglycemia, and it's also easy to examine. So here is a very, very large study that I believe is still ongoing, the DETECT study. And this is DETECT 2, where we could see that the risk or the prevalence of moderate non-proliferative diabetic retinopathy, even though it's low, between 6 and 6.5, at 6.5 A1C, it starts to rise. This inflection point is the reason why 6.5% is the diagnostic threshold for diabetes. It's really not more complicated than that. I will say that glucose, as we'll talk about, is not the only part of the story. And we do find that since glucose is elevated, triglycerides are also elevated, which probably also make an impact. And in fact, the ACCORD study did show that fenofibrate decreased this progression. So it's not just about glucose, but glucose is sort of the tying hypothesis. Now, the clinician's conundrum is balancing risks and benefits. We know we cannot achieve an A1C below 6.5 in actually the majority of our patients. And it has a lot to do with the burden of therapies, but it's also about hypoglycemia. This is from a type 1 diabetes cohort in the DCCT trial, which was changed really the paradigm of glycemic control in this insulin-deficient diabetes. But let me point out to you what you're seeing here. This is the A1C. And we have, say, we pick an A1C of 12, and we want to get this patient down to 7. As we do that, the risk of retinopathy plummets, but the risk of hypoglycemia rises. And even if we're choosing conventional therapies, we still potentially get to that risk place. And by conventional therapies, I would say including insulin. The idea with modern therapy is to try to change the conundrum and flatten this hypoglycemia curve, see if we can get to lower A1Cs without hypoglycemia so that patients will be able to live their life without severe microvascular disease. But this traditionally has been part of the big conundrum. Certainly is still in type 1 diabetes. So now, the other modifiable risk factors are really potent, actually. So in those who are having trouble achieving glucose control, we can focus them on cigarette smoking cessation, their lipid management, and high blood pressure. These three have been shown to have an impact in all forms of microvascular disease that I mentioned to you. Now, we know about screening, but of course, you know, the concept here is to teach the patient why we need to do it, because, you know, we need to get them linked in just like women are with mammograms. Our patients with diabetes really need to see their eye exam and their urine exam and their foot exam. It's critical for understanding where they are with their disease. So a couple comments. The fundoscopic exam is recommended actually within 5 years of diagnosis of type 1, but at the time of diagnosis of type 2. Why is that? Well, we know that type 1, when at the time of diagnosis, the disease hadn't existed for more than a year. That's safe to say because of the dramatic onset of insulin deficiency. Whereas type 2, it's almost always 5+ years into the diagnosis. We're a little bit better now because we're measuring a lot of A1Cs in our patients, so we can see that timeline. But the reason for the delay being allowed is because it takes time. I mentioned that. It takes about 10 to 12 years to see first signs of retinopathy in the average patient. And we'll get to a little bit more about how often we see it after 20 years. Now, urine microalbumin, we do recommend an annual UACR, urine albumin to creatinine ratio, which mimics that 24-hour albumin secretion quite nicely. I want to point out that there's an error on this slide, which is we don't use the term microalbumin anymore. That's not what our nephrology friends are telling us to do. They want us to just document the level of albumin and understand what's low and what's high. So we're looking for less than 30 all the time. When somebody's above 30, they have albuminuria. If they're above 300, that's considered moderate to severe. And we have special interventions for those people. Now, the foot exam, we say annual inspection, but I'm sure you know that once a patient has neuropathy, we need to look at that feet as much as we possibly can so that we can rule out risk of amputation. Okay, so let's go to the first case. Lucy is a 6-year-old woman who returns for routine diabetes follow-up. She's concerned about gradual onset of blurred vision occurring over months. She's had diabetes for 20 years, so red flag, she has microvascular disease. It's almost impossible to avoid. She's treated initially with oral agents, but she's now taking a multi-dose regimen of insulin analogs. She has background retinopathy. We already know that. And her last exam was about 2 years ago, unfortunately. Her glucose control is suboptimal. And that's why it's unfortunate that she hasn't gone annually. If her A1C was 6.5, skipping a year is fine for the ADA. But in her case, glucose isn't so great. Her visual fields are intact to confrontation. Tests of extraocular muscles are normal. And on confrontation, you really, you just see the background retinopathy. So she has gradual onset of blurred vision. So what do you think is the most likely cause of this woman's visual symptoms of gradual onset blurred vision? Okay, I think we can stop there. Looks like most of you selected macular edema, and then you're sort of, the question is whether cataracts could be on the list. And I think the main point is that you're recognizing that she could have a problem. Now, the most likely, statistically speaking, cause of this kind of presentation is macular edema. It's subacute often, but the point being is that it's not something that can be ignored. Many people with macular edema have scotomata. They have subtle symptoms, but if we don't treat it quickly, they can lose vision. And I think this is probably the number one thing we see in clinic where macular edema symptoms are not captured in our review of systems. Cataracts usually present with peripheral vision loss or complaints about night vision, but and they are usually subacute also. But of course, the ophthalmologist will detect both and be able to distribute or administer the right care. So excellent. So what is the prevalence of diabetic retinopathy? So we now say, I mean, this is a little old data. I think the data is we should do a better job, I think, collecting this data on a national and global perspective. But it's about a third of adults with diabetes who've had diabetes for more than 40 years. So that I would say in my practice, as you know, it depends on the glucose control and the type of diabetes. There is data showing that people with type 1 diabetes for more than 20 years, 100% have some level of retinopathy. However, since the 1980s and 90s, we've actually seen that change in some smaller studies. But it's important to recognize that most people with type 1 have retinopathy. And you know, I think after 20 years, we see different prevalence of diabetic retinopathy in the studies, as you can see. So as we treat our patient as an individual, we just want to understand where they're at. And we consider macular edema diabetic retinopathy. The other categories are proliferative, which is the highest risk for vision loss, and non-proliferative, which if patients are in the best shape when they have mild non-proliferative diabetic retinopathy, those are patients for whom we can intervene with glycemic control and blood pressure control and lipid management with the most effectiveness. So what I really wanted to convey to you is that the treatment for all levels of diabetic retinopathy actually includes injection therapy with vascular endothelial growth factor. This is generally used for proliferative proliferative diabetic retinopathy and macular edema. The idea is to stabilize and prevent vision loss. And the ophthalmologist used to use the laser photocoagulation for proliferative disease, but after several trials, pivotal trials were published, the injection therapy is now the mainstay for both conditions. What's important for you is to ask your patient when they're undergoing this therapy, when is their next injection? This, unfortunately, is not a highly durable therapy, meaning one injection is not enough in the vast majority of cases. In very early proliferative or mild, low density macular edema, I think I have seen patients just need one injection. It's very unusual. But what happens is patients get lost to follow-up, and they can have an advancement. They can actually revert back to where they were. So ophthalmologists do a good job, I think, reining in their patients, but it's good for you to engage, for me to engage. Tell me when your next injection is. And if they say they missed 3 appointments, then it's time to, put the pedal to the metal for them. Now, vitreous hemorrhages is unfortunately, it is rare, but unfortunately it does happen, and it is certainly leads to usually complete loss of vision in that eye, but not always. And it usually presents dramatically, and typically with pain, but it can be painless. So one final point is that tight glycemic control is only helpful based on the literature in people under 65. And it's not clear in the older adult if the glycemic control is going to make a major difference. And in fact, as we discussed in the prior lecture, achieving tight control
in a person over 65 could actually increase their risk of a retinal event. So so the risk benefit there of achieving tight control, you really need to understand what the retinal exam is and put that on your list of cautions. So, okay. And there we go. Let's go do the second case. This is Sam. Sam's a 44-year-old man with type 2, diagnosed 4 years ago. He's presenting for follow-up of recent lab tests. His A1C is 8.2. He has a urinary microalbumin to creatinine ratio of 45. His creatinine is 1.1 with a GFR of 70, and his LDL is 58 with triglycerides in the 280 range. Let's assume that's fasting. He's taking metformin, sitagliptin, which is a DPP4 inhibitor, aspirin, atorvastatin, and a fenofibrate. He smokes 1 pack of cigarettes a day. Recent dilated fundoscopy is normal. He has well-controlled dyslipidemia and sleep apnea. And on exam, his blood pressure is not well controlled, and his BMI is 34. So just a quick reminder, this is a 44-year-old man who does have nephropathy. He does not have retinopathy. He is a smoker. He has obesity and hypertension. And his GFR, this is because he has nephropathy. He does have a mildly reduced GFR, but he's still stage 1. Okay. So the first question is, in addition to diabetes with suboptimal glucose control, which of the following elements increases risk of progressive diabetic kidney disease? And you guys got it. So I think we're just going to go right through. Cigarette smoking is really, really important to identify and treat. Excellent. So now, once you talk about that, we have to decide what to do as next steps for him. This young guy with an A1C over 8. So you confirm the diagnosis of hypertension with home readings, he was already diagnosed, but we know that he's poorly controlled. In addition to counseling on lowering sodium, what is the best next step in medication management? And that's right, he's not on an antihypertensive right now. So you have options. You could add an SGLT2 and continue the sitagliptin and metformin. You could start the lisinopril. You could add a GLP-1 receptor agonist, stop the sitagliptin because they are both incretin therapies, and continue metformin. You could add canagliflozin and an ACE inhibitor and follow up with a basic metabolic panel and blood pressure. All right, I think we're getting the picture. I know you're getting the picture. Great. Okay, I think we'll move forward. We have a split between B and D, so this might surprise you, but this is actually one could argue the right answer, but truly this is an evolving field. Now, let me walk you through my thinking here. In diabetes management, we think now about getting the most out of an agent. And in this case, he does have nephropathy, hypertension, and hyperglycemia. His A1C is 8. He does have, he would benefit from a modest potency drug, moderate potency, I should say. And so adding the canagliflozin actually will address 3 things at the same time. Lower his blood pressure, improve his progression or slow his progression of nephropathy, and lower his A1C. Now, why wouldn't we start lisinopril? Well, because lisinopril will not do all those things, number one. And why wouldn't we just add both? And I'm going to just suggest to you that while that's not wrong, remember we had an MI case in our first talk, the idea is to avoid doing both at the exact same time. And that is really simple. I think that this patient could easily and should probably be on both at some point. But we do know from the Credence trial, when we look at the decline in GFR or the change in GFR
over time. We saw everybody's GFR went down over time. This is months, and this is the GFR. This is change in GFR. Everybody's GFR goes down. We know that. That happens with age. The outcome of this trial was that canagliflozin did better than placebo in that regard. But what do you see here? We see this acute drop in GFR. This is just actually very similar to what we see with ACE inhibitors. It's almost the same mechanism. So the ACE inhibitor will not protect the patient from that. It could actually make it worse. So we would generally recommend that in order to avoid AKI, which can actually occur and be problematic and result in hyperkalemia, that we just add one at a time. So that was the trick with that question. But excellent thinking. I think you are great. And I would just add that, the reason why the daily semaglutide was not the best answer is just because we don't have as great data on lowering blood pressure and improving nephropathy progression. Excellent. Great. So DKD, the prevalence is high, but to be honest, we're seeing a decline over time of end-stage renal disease cases, at least the prevalence. I would say the incidence is still high because the diagnosis of diabetes is not going down. But we have some hopeful thoughts, I do at least. We do see more diabetic kidney disease and end-stage disease and type 1 diabetes still, but that is also changing. So the progress, I think we've seen the most progress in type 1 because glycemic control is a focus. Type 2, we're seeing because of our multi-pronged approach with blood pressure control, cigarette smoking cessation, lipid control, and glucose control, we're actually seeing some really nice changes. But this is what I wanted you to see also, that in our patients over the age of 65, even though the decline, this is since 1998, for example, you see that there's a reduction in end-stage renal disease prevalence. In our older adults, it's still quite high. We're still seeing 300 cases per 100,000 people with diabetes. So lots of prevention to do, and we diagnose it based on the increased urinary albumin excretion. Again, we don't really say microalbumin anymore. We need to think about degree of albuminuria over a spectrum. Although we know that over 30 is considered abnormal. Very elevated, though, is different from moderately elevated when we look at epidemiology. So that's the reason why the concept is to just pay attention to where the patient's at. Over 300 milligrams, or the 300 on the ratio, is predictive, very predictive of renal failure. It's pretty impressive. And so at that point, we would want to be aggressive about management. The kidney organizations, and we actually will see a new guideline from KDIGO, I think, coming out next year. But the kidney organizations have consulted with the diabetes organizations to try to help guide how really to follow patients with CKD. And I'm just going to point out to you that we still talk about stages 1, 2, 3, A, B, 4, 5. But maybe what's more important is how often we should see patients based on their stage and then how severe their albuminuria is. So this chart is a little funny, but the idea is we should be monitoring their kidney function annually if they are in this, if they do not have albuminuria, but they have a decline in their GFR and they have diabetes. This is people with diabetes. We should treat and see annually. We should start to treat them with either an ACE inhibitor or SGLT2 inhibitor or both, if once they get into that 330 plus area. But once they're over 300, we really do want to see, we recommend referral to a nephrologist because their decline could be rapid. And then you can see how often we should be monitoring their kidney function. So it's twice a year. And then you can see it goes more advanced. I think this is actually pretty helpful, just to remind ourselves that there's a lot of room between 300 and 300, but once somebody's over 300, they really need to be watched extremely carefully. So what does the ADA say? They actually are putting the sodium glucose cotransporter 2 inhibitor right up in the front lights, along with the ACE inhibitor as a important treatment consideration because of the trial data. And then, of course, we saw that glucagon-like peptide, the GLP-1s, they also decrease progression of renal disease. But just a reminder for you, I think it's here, yeah, just a reminder that the SGLT2s do a better job. So the relative risk reduction with GLP-1s is about 15 to 20% as far as progression of kidney disease, and 30 to 50% with the SGLT2s. So SGLT2s are really the one to select for that. A couple other important points. We need to, as I mentioned, improve blood pressure. And like we saw with retinopathy, the impact of glucose control really does diminish over time. So at that point, the A1C isn't as important as making sure the blood pressure is under control and the agents used are appropriate. It attenuates with age. We don't give up on glucose control ever, especially if the patient is healthy enough and is not overburdened, but it does lose its value over time. Okay. All right. So let's go to Ralph. So Ralph is a 62-year-old man with type 1 diabetes for 25 years. He presents to your office for an urgent walk-in. He reports waking up with pain and tingling occurring on the lateral aspect of his left thigh 3 days ago. He's never felt this before. He's had no difficulty walking. He does have a history of TIA and MI, so he has macrovascular disease. His blood pressure is controlled. He takes aspirin. Blood pressure is well controlled. BMI is excellent. He's alert and oriented. His cranial nerves are normal. The painful area is non-tender. Skin is smooth and intact. His neurological exam is consistent with his recent exam, which shows stocking glove pattern polyneuropathy, poor vibration sensation. Vascular exam is normal, and his pulses are normal without notable edema. Okay, what is the best next step for this patient who developed acute pain in the thigh? So refer to vascular medicine for urgent lower extremity catheterization, reassure the patient, a nerve conduction study or a Doppler ultrasound to rule out a DVT. Excellent. Very good. All right. I think we'll stop there. So most of you selected to reassure the patient that this is a self-limited condition. Others were a little concerned that maybe we might be missing something, but that is the right answer. And we'll go through what the condition is that this patient has in our discussion of neuropathy. So diabetic neuropathy, this slide is just to identify for you that by the time somebody has symptoms, they're telling you they feel numbness and tingling or pain, they've had years of clinically undetectable or asymptomatic neuropathy. And the point is that, only 20% of people with diabetes, when it's been studied using fancy tests, electrophysiologic testing, for example, the nerve conduction, only 20% of diabetes patients don't have neuropathy. It's extremely common. The nerves are so sensitive. So what I try to communicate to my patients is that there's a lot of things happening in your body right now. You may not feel those symptoms that we talk about with neuropathy, but it's happening to you. And the glucose control today will protect you from misery tomorrow. So remember that, by the time we can detect this on clinical exam, it was already happening. We just don't employ these tests in routine practice, mainly because they're expensive and, the outcome would be the same no matter what, which is to achieve good control of the glucose. Now, the most common is the distal symmetric sensorimotor polyneuropathy. This is a stocking glove neuropathy. It doesn't really occur in any other pattern. So if a patient has dramatic unilateral paresthesias, for example, it is not reasonable to assign diabetic polyneuropathy to that condition. And I see that often. And I think it's really important to remember it just is a really reliable pattern of distribution. It can be a little asymmetrical. You can have worse disease on one side or the other. In a patient who's had a long-standing history of alcohol abuse, you can see it much earlier and much more dramatic because it's also stocking glove. We do categorize it. I think some people are unfortunate enough to have more C-fiber neuropathy. We don't know why. Some people are more prone to the painful neuropathy versus the more tolerable motor, vibration, touch, pressure, a large fiber neuropathy. Now, important pearl for you is to rule out B12 deficiency in all of your type 2 patients on metformin. And maybe I would say for your type 1s, because they are at risk for pernicious anemia, which is also an autoimmune disease. So make B12 one of your standard panel labs every year. I have caught B12 deficiency many times. Why does metformin increase our risk of B12 deficiency? It's not entirely understood, but we know it's quite clear. So please don't miss it because it can be misdiagnosed as neuropathy. Okay. Now, the treatment has not been advanced substantially. I would say the randomized trial data is being someone who does a lot of work on guidelines. It's of low quality. And that includes not just drugs, but other interventions. But I will tell you that gabapentin does still remain probably the most widely studied and most effective drug. But unfortunately, whether or not a patient will have substantial benefit from this drug is like flipping a coin. It's about 50% of the time. I try to encourage my patients to understand that we need to titrate this drug. This drug needs to start low and go slow and arrive at doses, close to 3,000 milligrams as needed. This is important because the drug is ineffective at very low doses, but we need to start low because of the side effects. Side effects of gabapentin include somnolence, lightheadedness, and certainly the concern would be falls, which we want to avoid 100%. Okay. All right. So just consider that it doesn't work for everybody. Other strategies do exist, and I'm going to point out pregabalin is very similar or less effective than Neurontin. It has a fancier name, and I think people do try it and they feel like they have better results. It's probably placebo in my opinion. But it's okay to switch. Just don't expect much. I would say amitriptyline is excellent for overnight control, and it's okay to use in addition to Neurontin. B vitamin treatments are harmless. I'm going to suggest that alpha-lipoic acid, 300 to 600 milligrams a day, is not a bad idea. The clinical trial data is reasonable, where we see patients reporting less symptoms, and it's just negligible in terms of side effects. So I do suggest that patients throw away their multivitamin and take B vitamins that we know have evidence to support neuropathy, where we don't have evidence for patients taking multivitamins without an actual deficiency. So the other thing I would say is opioids are minimally effective, and I have eliminated them from my practice for treatment of neuropathy because they get patients into other trouble. So back to our patient. What was wrong with him? Well, he had a classic example of focal neuropathy. I would say this is a form of vasculitis. It's an intravesicular infarction. It does take time to resolve, sometimes as long as 3 months, occasionally longer. But after 6 months, if the pain is not completely gone, I would refer the patient or go on to further study. But it's pretty classic. It will resolve. You can exclude, you should exclude other evidence of infarction or, a peripheral vascular problem in patients who are they're all at high risk of that. But when you see it, it's important to reassure the patient. Autonomic neuropathy is I would say, a silent neuropathy for many patients, but it is the most serious, in the sense that the demonstration of autonomic neuropathy actually is a very strong predictor of mortality. What do I mean by autonomic neuropathy? For the most part, we're talking about orthostasis in people with diabetes for more than 20 years, orthostasis that is resistant to hydration. And occasionally we need to treat it, but most of the time we're advising people who do have autonomic neuropathy demonstrated mostly by our orthostasis to take their time getting out of a chair, understand the problem, that their nervous system is not responding appropriately to changes in basically the effect of gravity, and that blood flow is not increased to their brain as quickly as it needs to be. But autonomic neuropathy can impair so many aspects of our nervous system. We all have patients with gastroparesis. I think we probably underdiagnose this condition, but that's because most people can treat with just modification of their diet, and they learn that on their own. But severe cases of gastroparesis do require pro-motility agents and reliance upon foods that have less fiber and less fat. Not the easiest, but I think referring to nutrition is important. Lastly, and not least, is the inability to detect hypoglycemia. This is a serious form of autonomic neuropathy where the sympathomimetic response to low blood sugar is blunted. And we actually treat that in diabetes. It's a reasonable reason to refer a patient, because we treat it by carefully raising their average blood sugar for up to 3 months so that they restore awareness. And that in about 60% of patients, it's effective. So something to think about. Then, of course, we all need to address patients with genitourinary autonomic failure, usually manifested by overflow incontinence. And then, of course, men respond heavily to counseling around erectile dysfunction prevention. I think it's important to bring it up. And women as well, decreased vaginal lubrication. We should be comfortable talking about our patients about these. All right, we have one case left, and this is Mary. She's 72. She's had type 2 for 15 years. She was initially diagnosed when she had an acute MI at 62. So it's 10 years after her MI. She's on metformin and insulin now. She was hospitalized for the flu recently. On physical exam, her blood pressure is quite elevated. Her BMI, she's lost some weight. She does appear well despite this recent course, and she's still quick-witted, but she's fatigued. She has slight crackles at both lungs, bilaterally, posteriorly, and some pedal edema. Her A1C is 6.1 when you measure it, down from 7.2 to 8 in the past. Her creatinine is 1.4 and her GFR is 46. Okay. She also has a random glucose lower than target. Below 70 is too low. So what is the best plan for next steps in management for this older adult who has the symptoms we described? We're going to either stop insulin and metformin, start Lasix, do a and a workup for heart failure, hold insulin, reduce metformin, and start empagliflozin, stop insulin, reduce metformin, and add a weekly GLP-1. All right, this is good. So we're really, really clear on this point, and I'm so proud of you all. So this is a really good case of sort of describing the focus on the heart failure. And as you know, you all can diagnose heart failure in your practice. You probably do it all the time. The idea here is twofold. One is that this patient is She's classically developing heart failure in longstanding diabetes. She also is developing some renal deficiency, insufficiency. Her glucose control has been too aggressive thus far, just recently, perhaps because of the weight loss and her renal decline, which may or may not be as so dramatic. But suffice it to say, we don't need the metformin and the insulin. We could potentially eliminate all diabetic therapies, but we need to treat her heart failure. Empagliflozin does not put her at risk of hypoglycemia, and it's the right choice to do two things at the same time. So just reminding you that heart failure is very common in diabetes, and we know that people with diabetes and heart failure have higher rates of death than people with heart failure in other comorbidities. And the pathogenesis, it's complicated, but we think it's related to longstanding exposure to high blood sugar in addition to cardiovascular atherosclerosis. Okay. So what can we do to protect our patients? Well, adopt a new strategy. Think about your patient in the next 5 years, 10 years, 20 years. Emphasize early the tight glycemic control because it doesn't pay off later as well. Modify known risk factors, especially smoking cessation. And then whenever you can, make room for those cardioprotective agents that also protect the kidney. I just want to point out that people don't realize this often, that fracture risk is increased in our type 2 and probably type 1 patients. Just remember that protecting people from falls and monitoring bone density is a really important strategy. As far as soft tissue complications, patients usually describe the trigger finger and the Dupuytren's contracture as the most disabling. But what I'm going to focus on for you, and remember, this is the accumulation of the advanced glycation end products in the tendinous tissues. Refer patients who have the terrible trifecta very quickly. These are patients that are going to lose function of their hands relatively quickly, in my experience. So carpal tunnel, trigger finger, and contracture, they need to see a hand surgeon. All right, take home points. We have made it. Okay, so comprehensive goal-oriented care in diabetes is effective. We know this. Doing everything at the same time sometimes does pay off. Microvascular and soft tissue disease, they remain highly prevalent. And early cardiovascular death rates are declining, which is great. And we do think of microvascular and soft tissue diseases as not really accelerating death, but accelerating misery. So it's important to think about preventing these as well. So achieving glucose control is probably the most important thing to do to protect people. And then adding lipids, blood pressure control, and smoking avoidance is critical. And of course, we spent a lot of time talking about the SGLT2s and GLP-1s, and I hope you feel a little more comfortable incorporating them. Thank you so much to everybody. Appreciate it.
Great. Thank you, Marie, so much. That was just a superb review of all of the complications. You've got so many questions. I'm going to start firing through. So if you can keep answers as short as possible. Sure. Medicare patients coverage puts many diabetic medications in tier 3 or 4. How to manage the cost of medications, particularly the SGLT2s, GLP-1s, et cetera.
It's really critical. I would say first, focus on what you can do, and glycemic control can be achieved by the other agents. But Medicare are older adults. They need glycemic control, but they also need comorbidity management. So the companies do have helpful tools to some extent. I would say controlling the costs quickly. I'll just give you one hint. Empagliflozin is a 25 milligram pill. We get a lot of bang out of that buck from just 10 milligrams. So prescribe the 25 milligram tablet, ask the patient to cut it in half. They get sort of twice as much drug for the cost. There are a lot of other things we can talk about, but important, and I don't have a good final answer there.
Speaking of SGLT2, do you need to start at a low dose? And can you use it in patients with type 1 diabetes?
So Great. Yes, you should start at a low dose. I have colleagues that might disagree with me, but in my practice, there's just no downside to low dose SGLT2s. You can really see how the drug will impact people from a symptoms side effect perspective. And you should not use it in type 1 unless unless a couple of people are watching the patient. I have 2 patients that I'm using it off label on for unique reasons. And reach out to me if you want to talk about it. Happy to explain, but I would avoid it.
Okay. Just quickly, in 12 seconds, how do you monitor in patients who have hemoglobinopathy where you can't get an A1C? Do you use fructosamine, and are there any standards for that?
Okay, great. I'll tell you what I do in my practice. I use continuous glucose monitoring in those patients because it's so easy to access and you can get a real mean glucose, but fructosamine is a good alternative, yes. Just remember, the normal range of fructosamine is the normal non-diabetic range. It's not the acceptable range in diabetes, if that makes sense. So it's not as helpful, I would say.
Thank you, Dr. McDonald, for a fantastic 2 talks. We will email the other questions to you, and then if you can send some answers to me, I'll go through them in the Q&A. Thank you so much.